Welcome everyone to the SAB September Educational Webinar event, New Bronchoscopic Advancement in COPD Treatment with Dr. Shostak. Before we begin, just a few reminders to anyone new to the SAB webinars. You all are currently in a listen-only mode and you are muted. If you have any questions throughout the lecture, we encourage you to submit them by using your question feature. It is located on the control panel. Under the question is the little drop-down box. We'll address all the questions at the end of the presentation. Dr. Hussam Naif will be tonight's moderator. He sits on our Education and Program Committee as well as our Chair of the Industry Relations here at the SAB. And at this time, I'll hand it off to Dr. Naif to get us started.
Okay, well, welcome everyone to the Society of Advanced Bronchoscopy Educational Webinar. Your host today, Hussam Naif. We present to you on a monthly basis discussions and reviews in advanced bronchoscopy and interventional pulmonology with leaders and experts in the field. Today we have a very exciting topic, the new bronchoscopic advancement in COPD treatment by the one and only Dr. Shostak. I have the honor today to present to you Dr. Eugene Shostak, who's the Director of Interventional Pulmonology and the Assistant Professor of Medicine in Clinical Cardiothoracic Surgery and Interventional Pulmonology at Weill Cornell Medical School of Medicine. Dr. Shostak had completed his training in pulmonary critical care at Weill Cornell, and he completed his interventional pulmonology at Beth Israel Mass General Hospital. Without further ado, Dr. Shostak.
Thank you so much. Thank you for the opportunity, and thank you, SAB, for having me here today. And today's topic will be lung volume reduction, and we'll go over both bronchoscopic as well as surgical approaches to lung volume reduction. And hopefully we get some questions at the end as well. So lung volume reduction for emphysema is centered around the idea that hyperinflated lungs are exerting pressure on the diaphragm and inspiratory muscles. And if there was a way to reduce the degree of hyperinflation, that will translate into an improved mechanical changes and subsequently improvement in patients' dyspnea and quality of life. One of the important goals of the procedure is for the diaphragm to move upwards, which will correlate with improvement in the mechanical degree of hyperinflation. Physiologically, we think that VQ mismatch or improvement in the VQ mismatch is the reason behind improvements in FEV1 diffusion capacity, such that distribution of blood flow will flow away from the area of the lung that's been closed towards other areas of the lung that are better perfused. We see from the slide that there's been a lot of interest in lung volume reduction to be performed bronchoscopically, and this slide is a nice summary of what's been happening over the last 20 years. We see from the slide that the clinical trials have focused on multiple different phenotypes, including patients with both heterogeneous and homogeneous emphysema, patients receiving upper lobe and lower lobe treatments, and we could see that as a result of multiple clinical trials, we think we now have a better understanding of a particular phenotype that may benefit from this procedure, which we will discuss. Now, we also see from the slide that there's really only been one clinical trial, which is the famous NET trial published in New England Journal of Medicine, that looked at surgical treatment of lung volume reduction and advanced emphysema. And so that's also sort of an interesting observation that further supports the need for a less invasive approach for these patients. What is the difference between surgical and bronchoscopic lung volume reduction? Well, we first of all need to understand that nowadays almost all of the surgical procedures are done with a minimally invasive approach, whereas in the NET trial, only 25% were done with VATS and 75% were open thoracotomy, so we don't do that anymore. Obviously, valves are reversible, surgical is not. I think one of the biggest differences is the phenotype of the patient that we select. So we know that upper lobe predominant heterogeneous emphysema is appropriate for patients undergoing surgical lung volume reduction, whereas a bronchoscopic lung volume reduction also includes patients with homogeneous disease and patients with lower lobe emphysema. So we have a much broader pool of patients that may be candidates. The big caveat, which we will discuss in the next couple of slides for a bronchoscopic procedure, is presence of fissures. There needs to be no collateral ventilation, no communication between the lobe being treated and the ipsilateral lobe. And so that requirement does not exist for surgical lung volume reduction. And as we will see later, absence of complete fissures will often be the most common reason for patients being disqualified from a bronchoscopic procedure. This is a very practical summary of inclusion and exclusion criteria for the procedure. These are based primarily out of studies sponsored by Pulmonx. Some of these parameters have been borrowed from the NET trial. So we know that for a bronchoscopic procedure, both heterogeneous or homogeneous emphysema patients could be eligible. FEV1 has to be under 45% predicted, but above 15% predicted. Residual volume, at least 150, but ideally 175% of predicted, has to be based off of body plethysmography. So if you don't have access to a body plethysmography, if you're using nitrogen or helium dilution technique, I usually say do not pay attention to the residual volume because it'll probably be lower than it really is. And so we often educate our referring colleagues not to exclude patients on the basis of a lack of hyperinflation if they don't have access to a body plethysmography. We have a couple of other inclusion criteria on the screen. I think 6-minute walk test is important. Patient has to be able to walk a certain distance. Patients that are debilitated in a wheelchair may not be good candidates for this. I think the last one on the slide, no collateral ventilation, is probably the most important criteria, where we know that a valve procedure can only work if there is no communication. And then exclusion criteria are sort of they're common sense. I mean, severe pulmonary hypertension, which is out of proportion to COPD. Patients who had prior lung surgery are usually excluded, same as pleurodesis patients, because they may not be able to develop atelectasis. But we do approach patients who had wedge resections sort of on a case-by-case basis, with the understanding that the procedure may not be successful. Certainly, if a patient had a lobectomy, then that patient is excluded from a procedure on the same side and on the opposite side as well, because all of the clinical trials treated only one side. So although there may be occasional experiences here and there where patients get bilateral treatment, but we need to understand that this is meant to be a one-time unilateral procedure. Hypercapnia, PCO2 more than 55. Usually those patients would benefit from non-invasive, and then a couple of months later you can repeat a blood gas, and if their PCO2 is back to something reasonable, that may be a way to approach this. Patients with large bulla, those patients are usually best served with a bulectomy. And what I don't have here, and I just recently had a patient like this, nickel allergy. Not very common, but important to inquire because valves are made out of nickel. So when we obtain a CAT scan, we send the CAT scan to a company, and there's two valve companies out there, Pulmonx, which makes the Zephyr valve, and Olympus, which makes the aspiration valve. Both of those companies have a software that is able to analyze the CAT scan and provide us very helpful information to assist us in patient selection. This analysis here is based on this software that analyzes the CAT scan and tells us, number one, how much emphysema is there. So this is a quantitative assessment of emphysema, and this is really based on the voxel density. If you remember, voxels are measured in Hounsfield's unit. The more air you have, the closer you are to -1,000. So pure air is -1,000, bone is positive 1,000, and so if you use a cutoff of 910, -910 Hounsfield's units, with that arbitrary cutoff, we can say that anything less than 50%, meaning that there are less than 50% of voxels that are less than -910 Hounsfield's units, is shaded white, which means not significant emphysema. And then as you get more and more percentage of these voxels that is closer to -1,000, you get more and more closer to the black, which is greater than 70% voxels. And in clinical trials, if you're using this particular cutoff, investigators said arbitrarily that 50% or less is considered normal lung, and above 50 may be treated. And so that's how you come up with those numbers. Those are arbitrary numbers. If you use -950 Hounsfield's units, then your numbers are going to be lower, and then it becomes 35. 35 is sort of the number that we look for. So in addition to giving us a quantitative emphysema assessment, we also better understand completeness of the fissure. Again, this is artificial intelligence algorithm that looks at a fissure. You should always review your own CAT scans. I've seen many discrepancies, but gives you a rough idea that if a fissure is 100% or 95% complete, chances are that that fissure will be sufficient for the procedure. Inspiratory volume is the bottom graph. Okay, so because this is an inspiratory CAT scan, the computer can easily calculate how much volume there is in each lobe. So how do we pick a target? Well, ideally, you would want to have the most amount of air with the most emphysema and a complete fissure. So it's really mix and match, and sometimes you get a great target, and sometimes you don't. Sometimes the best target may not have a good fissure next to it. So you sometimes have more than one target that you can go after. So this report looks a little different because this is from a Olympus company. The concept is absolutely the same, but these guys use -920 Hounsfield's units to establish their cutoffs. And because they're using a slightly higher cutoff, they say 40% and above will be considered as clinically significant emphysema that warrants treatment. But and then you have the same scale, and the darker the color, the more emphysema. You also have fissure completeness scores. You have inspiratory volumes. Otherwise, very similar. Also, what you notice here is that a complete line is considered more than 90% complete. And that number, 90% and above, is an important number, which we will get to in the next couple of slides. So these are obviously fissures. What is interesting is ever since, I've learned a lot from my thoracic surgical colleagues. And one of the things that I've learned is that right upper lobe fissure is almost never complete. And I think that many thoracic surgeons will agree. When they go in to do lobectomies, they almost always have to divide the fissure because it's incomplete. And I have seen this many times in practice, despite of what these CAT scans or these reports are showing, very often, or more often than not, at least, the right upper lobe will not be a target for that reason. So it's statistically speaking, the left side is better than the right because there's only one fissure on the left, and so there's less probability of having interruption. So we've spoken about fissures radiographically. And right now we're gonna talk about fissures functionally. So how do we assess a fissure intraprocedurally before we place valves? So Pulmonx company has developed their own proprietary machine, which is called the CHOTUS, and this machine allows you to measure flow by inflating a balloon, inserting the balloon and occluding the target lobe, and then the balloon has the little green tip is a little flow sensor, and by occluding the target lobe and being able to measure flow, you can better understand whether you have collateral ventilation presence or not. Because as you see on the left side of the screen, over a period of time, the expiratory flow disappears, and there is a reciprocal increase in airway resistance. What that means is that the fissure that's being under question is intact, because you inflated the balloon, so air cannot get into the lobe, and because the fissure is intact, you have decreasing flow. On the right side of the screen, however, you have an opposite phenotype where you have persistent flow, and that of course means that the flow is coming through an interrupted fissure. So this is a functional assessment of fissure integrity, which we perform routinely during the procedure. Now, interestingly enough, not every center will perform this, and there is some discussion within the community in regards to this particular step of the procedure. How important is it to perform this? And the reason why some institutions do not perform this is because Olympus company that sponsored the trial using spiration valves, you only looked at the CAT scan, and they said 90% and above will receive valves and less than 90 will not. And so that is and they obviously had also a positive outcome. This is why we have FDA approval for those valves. But that is the reason that not every institution will perform this analysis. My own biased opinion, my own personal opinion is that this is a very important part of the procedure, because we have seen over the years patients who have had collateral ventilation detected on this that had that had fissures more than 90%, and vice versa. Patients with fissures less than 90% who did well with valves because they had no collateral ventilation. But it is a discussion, and you may see that variability. So the Liberate trial is an important trial to read and be familiar with, because this was the trial that pushed the Pulmonx or the Zephyr valves through the FDA and granted approval at the end of 2018. This was a trial published in the Blue Journal, which was a randomized trial looking at patients with upper lobe predominant heterogeneous emphysema. And this trial was relatively large for a valve study. It was actually the largest clinical trial, 190 patients with a 2-to-1 randomization. The primary outcome was more than 15% improvement in FEV1. And as you could see here, at a 12 months mark, there was a significant improvement between the two groups, significant difference in terms of primary outcome. Secondary outcomes are listed here: FEV1, 6-minute walk test, St. George respiratory questionnaires. All of those demonstrated significant improvement from baseline. If somebody asks, some patients are very educated, and they may ask what are the absolute numbers. You could tell them 100 cc's or 104 cc's improvement in FEV1, 39-meter improvement in 6-minute walk test, and about 4-point drop in SGRQ. So all of those are both statistically and clinically significant at 12 months. Excuse me, SGRQ drop of 7 points. So what are the most relevant, clinically relevant complications that you should be discussing with your patients? Pneumothorax. Pneumothorax is very prevalent. 1 out of 3 patients will develop a pneumothorax. Those pneumothoraces happen in the first couple of days of the procedure. And the reason why pneumothorax occurs, we believe, is because the ipsilateral lobe will expand to fill the space that was previously filled by the lobe that was just closed. And in the process of this expansion, you should expect a pneumothorax, particularly if there is significant emphysema present. So a pneumothorax is not necessarily a marker for bad outcome. It may be viewed as a setback, a temporary setback, but all of the patients in clinical trials who developed pneumothoraces did just as well as those who did not. A brief summary of an impact study. Impact study was the only, or is the only, trial that looked at homogeneous emphysema patients. So when we say that FDA approved both heterogeneous and homogeneous emphysema patients, you should know that out of that that initial graph that I showed with over 10 studies, only one was performed with homogeneous patients. So the evidence is much weaker, but sure enough, these patients showed significant improvement. It was a smaller study, only 33 patients in the intervention group and 46 in the control. Primary outcome was change in FEV1 at 3 months, and you could see the p-values are nicely highlighted, both FEV1, residual volume, and then subjective things like St. George, 6-minute walk test, MMRC. All of those showed significant change between the two groups. So this is the reason why we are offering this to homogeneous emphysema. Remember, Olympus spiration valves were not studied in homogeneous patients. So the FDA approval for homogeneous is only with Zephyr valves. And we talked about the conclusion. So the IMPROVE study is the equivalent of the LIBERATE study. So this is the Olympus-sponsored study with spiration valves that ended, and the results got released a little bit later, a little bit after the LIBERATE trial. It was a very similar type of a study in terms of the selection criteria. You notice the RV was a little bit lower here. It was 150. In the LIBERATE, it was 175. So in clinical practice, we often say 150 is the bare minimum. PCO2 was a little bit higher here. It was 55. LIBERATE was 50. But as I mentioned before, fissure completeness was defined only based on a CAT scan, more than 90% complete. All right, so they did not use the Chartis. It was also a 2-to-1 randomization, and interestingly, they included a couple of patients with alpha-1 antitrypsin deficiency. There were no alpha-1 patients in the LIBERATE trial, so therefore, FDA approval for alpha-1 only extends to spiration valves. These are the results, very similar to LIBERATE in terms of both subjective and objective improvements. So some subtle differences between IMPROVE and LIBERATE trials. There was similar degree of improvement in the primary endpoints. Complications, interestingly, were very similar in regards to pneumothorax. I would say the biggest difference is that they did not use the Chartis, and they still got good results. And we talked about some differences in FDA approval in regards to alpha-1 and homogeneous emphysema. So the workflow for a patient who's presenting for an evaluation and consultation is to obtain PFTs in the body pleth. Make sure that the CAT scan is done with 1.25 millimeter cuts. That will allow you to submit it and generate the StratX report. Now, the Olympus can take 1.5 millimeter cuts, but there's something very important which we did not realize for a while, but we figured this out at some point. When you request 1.25 millimeter cuts, many radiology facilities will provide you those images on the lung windows. But if you look at the mediastinal soft tissue windows, you will not see 1.25 millimeter cuts. And that is because usually you don't need thin slices when you're looking at a mediastinum. The problem is that when you submit the CAT scan for analysis, it's not the lung windows, it's the mediastinal windows that the software looks at. So you may think you're submitting an adequate CAT scan and the system will not alert you, but you may potentially obtain inaccurate results. And so you have to make sure when you speak with your radiology colleagues that they push all the images into packs, including the thin slices into the mediastinal windows. It takes up more space in packs, which is why they don't do it routinely, but it is important, and we've caught this. We caught on to this eventually, so that's a very important clinical pearl. Once we submit a CAT scan, we obtain a StratX report or a Select CT report, which is the Olympus equivalent. We do a blood gas, we walk a patient. Pulm rehab is always a great idea, but we all know the practicalities about pulm rehab. It's not always available, and so we don't make this a hard inclusion criteria for valve procedure. And we're going to talk about a perfusion scan because we initially did perfusion scans only for homogeneous patients. We now do them for all of our patients, and we do a lobar perfusion scan, which I'm going to show you in a minute. So here's an example of a StratX report, which we can review. This is clearly a patient with homogeneous emphysema. Apparently has great fissures everywhere, and inspiratory volumes are provided. And the question is, how do you know? How do you pick the target? When you have homogeneous emphysema, you must absolutely get a perfusion scan because that will be the tiebreaker. The traditional planar SPECT scans are actually not helpful in our situation because they break up perfusion into upper, middle, lower zones. Now, if you're talking about valves, you're talking about lobar atelectasis. So if you are treating the left upper lobe, for example, it is very hard to figure out where's the middle zone in relation to the left lung. You have 3 zones, you only have 2 lobes, and you could potentially make the patient feel worse if you treat the wrong area. And even on the right side, the upper zone does not always correspond to the upper lobe. So zonal perfusion scan is more helpful for LVRS patients because they undergo apical wedge excisions, which usually corresponds to the upper zone. So we need a better technology, and in some institutions, including mine, there is a SPECT VQ scan technology, which is essentially an overlay between a CAT scan and a SPECT. And this way, you're able to better approximate lobar volumes. Hopefully the video plays, and this is an example of a SPECT VQ scan, where you see color that corresponds to perfusion. What is also important to understand is that the way the system calculates lobar volumes is by a radiologist manually drawing the fissure. So if you don't draw the fissure correctly, then the computer will not give you the correct information. So the information is only as good as the fissure that's drawn. That's why they always like to look at a diagnostic CAT scan first, because then they know exactly where the fissure is. And if there is no diagnostic CAT scan, then it becomes much more difficult for them. And we've had many instances of inaccuracies that were, when we discuss these cases at our monthly conference, we can catch those and correct them. So that's just something important. It is not automated, but rather it is a radiologist who has to draw in the fissures. So to switch gears a little bit, lung volume reduction surgery. You know, some people think that valves are here to replace LVRS. I don't think that is true. And I think lung volume reduction surgery is an important part of a multidisciplinary approach to any lung volume reduction program. Why? Because as we will see soon, many patients are not candidates for valves due to various reasons, usually anatomical related. We know that based on the NET trial, we know that the phenotype that we're looking for LVRS are patients with upper lobe emphysema, patients who have FEV1 of more than 20%, patients who are non-smokers, and patients who have undergone a pulmonary rehab program. So for LVRS, we do ask patients to undergo pulmonary rehab before we move forward. Also, as a reminder, the only group of patients that should undergo LVRS are patients with upper lobe emphysema, heterogeneous emphysema, and low baseline exercise capacity. If you have if you have access to a CPAP, you can obtain exercise capacity, but we don't do this routinely. But that is the only phenotype. All the other phenotypes did worse with surgery. Also, as a reminder that when the NET trial was published, these were mostly open resections with a median sternotomy. We never do that nowadays. Nowadays, the procedure looks something like this: either single port or 2 to 3 ports, VATS procedure, and some of the things that the surgeons have taught me is that when they staple off the bulla, they also take down adhesions so that they can mobilize the diaphragm. The diaphragm comes up. Patients usually will get talc pleurodesed at the same time, and sometimes if there is a space issue, then a pleural tent, which is what you see on the right side of the screen, we can drop a part of the visceral pleura and form a tent, which will help with apposition and pleurodesis. So these are all of the tricks that the surgeons can do at the time of their operation. We as pulmonologists don't have ability to mobilize the diaphragm, take down adhesions, right? So when we put in valves, we cross our fingers and hope that there is atelectasis, and sometimes there is, and sometimes there isn't. And sometimes there's no atelectasis, not because you did something wrong, but simply because these patients have adhesions that do not prevent the lobe from closing. These are just some interesting pictures for us to better appreciate what the surgeons deal with when they go into a case. This is a bulectomy case, and again, being able to separate bulla from lung is very important. Surgeons have always taught me that when you fire a stapler, it has to be on the normal lung, not on the bulla, for obviously to prevent air leaks. So this is sort of what it looks like on their side. So I in the remainder of the time, I wanted to go over a couple of cases just to keep this dynamic and just to share some clinical experience. So here's our first patient: FEV1 36% up to 43, RV 171 to 178, diffusion capacity 2% predicted. Obviously, that's effort dependent. So you know, a good lesson that don't look at diffusion capacity if the numbers don't make sense. So this patient fits the profile based on the PFTs. I always look to make sure the volumes were done correctly in the body pleth, which they were. This is a StratX report on this patient. So this is a heterogeneous emphysema that's upper lobe predominant. We quickly see that the right upper lobe is worse than the left upper lobe. However, the minor fissure is incomplete, which it often is, as we mentioned earlier. The left-sided fissure is 93% complete, which in my mind translates to about 50-50 on whether or not she will have collateral ventilation. And so this patient has really two options. One option would be left upper lobe valves. Another option would be right upper lobe LVRS. And both of those options were presented. Now, also if you just direct your attention, inspiratory volume of the left upper lobe is 2 liters. Left lower lobe is less than 1 liter. So that becomes important because in this case, we know that the left lower lobe is very healthy. So that's a great case. We're very excited about this case because we can really expand the left lower lobe and have that left lower lobe take over And because it's so healthy, we think that the patient will do great. But if you could imagine, let's imagine this lobe was not so healthy, then I would be concerned because I'm asking a lobe that's only 700 cc's to fill the space of almost 3 liters. So over time, with clinical experience, you start to sort of better understand which patient can get away with this and have benefit versus which patient will get into trouble with air leaks and a space issue. So this patient chose to undergo bronchoscopy with valves. We inflated the balloon in the left upper lobe, and as you could see, in less than a minute, this is a 1 minute mark, in less than a minute, we have complete cessation of expiratory flow, which promptly returns as soon as the balloon is deflated, which suggests that the left upper lobe fissure is good. This is a short video showing deployment of the Zephyr valves. You notice that in terms of technique, you have to place the catheter against the distal carina, deploy slightly, readjust, push it forward, and continue your deployment. And so what keeps the valve in place is the distal carina. There are ductbill that opens and closes, which allows air to exit but not re-enter. The deployment of the aspiration valve is even simpler because there's no need to find the distal carina. The valve has little hooks on it, so as long as you place it into the subsegment, it'll stay in place. And here, and again, I may be one of few. I don't know if anyone else does it in other institutions, but I do like to use both valves. And as you can see here in the left upper lobe, we have both aspiration valves and Olympus valves next to each other. And I think a total of 4 valves was placed, and the patient did very well. What's nice about these valves is that you could see them on an X-ray, so they look very different on an X-ray. And then over the next subsequent couple of days, you could see how nicely the left upper lobe starts to close. But when you're looking at atelectasis from a valve procedure, it looks very different than atelectasis from what we're usually used to seeing, which is tumor that's obstructing a lobe, or mucus plug, or a blood clot, where the volume of the lobe is still the same. It still occupies the same volume, it's just the lung is atelectatic, whereas here, that left upper lobe essentially vanishes. And the entire space now is filled with the healthy left lower lobe. You could also appreciate how the diaphragm, remember we talked about the caudal displacement of the diaphragm being one of the goals of the procedure. Well, luckily for her, she didn't have a lot of adhesions, and we had a very nice caudal movement of the diaphragm of almost 9 centimeters. So this patient went home. In my program, we keep them for 4 days usually. She did not develop a pneumothorax. And 3 months later, her FEV1 is up to 54, residual volume normal, diffusion capacity 47. If you calculate the math, she actually demonstrated almost the same exact changes in FEV1 and residual volume as we appreciated in the Liberate trial. And she came off of oxygen, and she's doing very well. So when I'm seeing a patient in consultation, the patient will always ask, what is this going to do for me? What type of improvement should I expect? And I think it's a very complicated question to answer, but I think that if we have a phenotype like this patient with a healthy lobe and a lobe that can be closed, we could really expect the patient to do well and come off of oxygen. When we have homogeneous emphysema, or when we have more diffuse degree of emphysema, even if it's heterogeneous, I think the benefits are still there, but they may be less robust. So here's a second question for the group. What are the options here? And as you could see, this patient has most of the tissue destruction in the right upper lobe. However, we appreciate on the CAT scan that the right upper lobe is basically one giant bulla. So this would not be a good case for a valve in the right upper lobe, even if you had a good fissure in the right upper lobe, because we know that large bulla are best served with a bulectomy. And so bulectomy would be a good option for this patient. I suppose left upper lobe valves could also be an option if the patient did not want surgery. But this is an example of a giant bulla that you typically would not put valves for. What about here? I hope this projects well. Well, here we have a patient with a healthy left lung, and we have a patient that has heterogeneous upper lobe predominant emphysema in the right lung. Fissures are incomplete in the right lung, so this patient would be a candidate for LVRS in the right upper lobe. So these are some of the examples of how it's important to be able to think broadly and really function in a multidisciplinary environment, because lung volume reduction program is obviously a lot more than just valves, but it's really tailoring the approach to each individual patient. How about this patient? Well, one of the exclusion criteria in the Liberate trial is if you have more than 70% tissue destruction, which is color black, if that's present in both lobes, then that patient was disqualified from a clinical trial. So in this example, you would not treat the right side with valves because there's too much emphysema there. And so this patient may be, depending on their age, comorbidities, may be a transplant candidate. How about this patient? So this is a homogeneous patient. You could see that their emphysema scores are very similar. A little bit worse on the right than the left. This patient does not have a good fissure on the left, and this patient has what seems like a reasonably complete right lower lobe fissure, right major fissure. And here we always have to turn to perfusion scan. And the perfusion scan tells us that the right lower lobe is receiving 35% of perfusion. So an important question comes up is, what is the maximum amount of perfusion that you can sacrifice? And we think that the answer is 20, because in the LVRS NET trial, those patients who underwent bilateral procedures on average had 10% of perfusion to the upper zone. So that's how we can come up with 20. I don't think anyone really knows the answer, but 35 seems to be on a higher side. And then what else is interesting here is that if you look at the volume, the right lower lobe volume is 1.7 liters, and the right upper lobe volume is 1 liter. The middle lobe is, in this particular patient, even though it says 280, but actually that middle lobe is atelectatic from chronic lung infections. So that 200 it gets added on to the right upper lobe. So there is more volume in the right lower lobe than in the right upper lobe. So if you close the right lower lobe, the way to think about it is that now you're asking essentially the right upper lobe, because she has no right middle, you're asking the right upper lobe to fill the entire space of the right hemithorax. All right. So 1 liter of the right upper lobe will now have to fill a space of almost 3. So unlike the prior case of a patient who would put valves in left upper lobe, where in that patient left lower lobe was very healthy, here if you look at the right upper lobe, it is far from healthy. And so this is a patient who I said that we should not move forward because there's a very high risk of complications, including air leaks and space issues. So again, these are some of the ways in which you want to think about which patients you offer the procedure to. So the reason why this patient is not a candidate is, number one, too much perfusion to the right lower lobe. Number two, too much volume or too little volume of the remaining right upper lobe. I want to show you an example of a patient who, at least to me, served as an example. and made me appreciate better some of the problems that you can encounter related to a space issue. This is a patient who had a left upper lobe valve procedure. There is obviously a chest tube in place. He's having a really bad leak. Left upper lobe is completely closed. You can see that he has a space because his remaining left lower lobe could not fill the space. He also aspirated on top of that. So he was on high flow at this point. And so sometimes a question comes up, how do you troubleshoot these situations? Well, if you have lobar atelectasis and the ipsilateral lobe does not fully expand and you have a leak, then your only option is to remove a valve. So this patient underwent removal of 1 or 2 of his valves, which allowed everything to open up, and then we were able to pleurodesem. So it's a bad problem, and it's something that we have to always be cognizant of. So this is all I have, and I hope you guys enjoyed it. I hope that we can get a couple of questions. And again, thank you for everyone's attention.
Hey, Dr. Shostak, thank you so much for this awesome presentation. I had a question on my own, and I wanted to always leave the questions for the audience. But how do you prepare the patients mentally for a 30% or 33% possible pneumothorax? How do you handle that?
So what is really fascinating about this entire procedure is that and this has actually been shown in studies, that these patients are so symptomatic and their quality of life is so poor that, as sad as it sounds, they really will sign up for anything. It is you could sell them a bridge, even though you tell them risk of pneumothorax, some patients, we tell them there's risk of prolonged intubation, even respiratory failure. All of these red flags that typically would deter a patient from pursuing an intervention. In this particular instance, these patients are nothing but grateful. And that has been actually studied, and research shows that when you cannot breathe, that is the most disabling symptom. Another related question that comes up often is that when you close a lobe, you will lose ability to follow the patient either for lung cancer screening or if there was a nodule in that lobe, right? So obviously we need to make sure that the nodule is stable. But I tell the patients, look, you're obviously a heavy smoker. You are at risk for lung cancer. If we close one of your lobes, we will not, theoretically, you may develop a lung cancer in the next year or two in that lobe. We will have no idea. And patients never, in my experience, use that as a reason not to move forward, because to them, breathing is
not feeling well.
Yeah.
Awesome.
So now on our end, we have to prepare ourselves for pneumothorax. And there is different types of pneumothoraces. There is a pneumothorax where, the lung pops, you put in a pigtail or a chest tube, and there's a leak, but that's, it resolves and the lung expands. And then there are other patients where you could sometimes forecast a disaster, which is where there is a lot of emphysema. You will create a space problem. You cannot pleurodese, and you may have to take the valve out. So that's how we should prepare ourselves and if there are concerns in that regard, then maybe that patient should not have a procedure.
Yeah. A segue to and a follow-up question, and then that's more technical, procedural, and post-op care. So what's your sort of go-to marker that, okay, I need to go and take out the valves?
Well, so there would be two situations in which a valve would need to be removed. One situation is post-procedural if there is unexpandable lung and a continuous air leak, right? That's a space problem. It cannot be fixed in any way other than taking a valve out. because then you can close that space by reinflating the lung, and that's essentially considered, you know, whether you take out one valve or all of them. Basically, once you take out one valve, the lung is going to expand, the lobe is going to expand. So the procedure is basically
lateral ventilation.
Right. The other scenario is that patient doesn't feel better and you did not close the lobe. So as an outpatient, 3 months later, we usually do a scan about 45 days later, but at some point, a few months down the road, or even sooner, you may realize that this did not work. And you could sometimes, on a repeat CAT scan, you may be able to find, you know, if there is a movement or a migration of the valve that. So if you see something definitive on a CAT scan, that's great. You should absolutely rescope those patients and fix it. But to tell you the truth, sometimes more often than not, when we do CAT scans on these patients, we don't find anything wrong. The valves are perfectly positioned. We comb the CAT scan with our thoracic radiologist, and we don't find anything wrong with the CAT scan. And so in that situation, yes, we will scope the patient, but the probability of finding something fixable is very low. And the explanation may be either that the fissure is interrupted, maybe microscopically, and it didn't really, it wasn't obvious during the preoperative assessment, or there are adhesions, and you cannot close the lobe simply because of scarring and adhesions.
Okay, well, thank you. We do have a question. How do you feel the necessity of the multidisciplinary team, and did this affect your outcomes before and after, if there was any comparison, and if you could elaborate more on who's in that who sits on that table, like who's your team when you're talking about multidisciplinary?
So at my institution, luckily we have shared interest in this procedure among us thoracics, diagnostic radiology. So we have a thoracic radiologist, diagnostic radiologist who's very interested in looking at these CAT scans. And in fact, when we order a valve protocol, so to speak, which is basically just a thin slice CAT scan, the radiologist will specifically comment on fissures, and they will tell you minor fissure looks interrupted, et cetera, and a nuclear medicine physician as well. So they're the ones that look at perfusion scans. They're the ones that draw those fissures. They draw them in manually, then they report on the perfusion. So that is our team: thoracic, IP, radiology, and nuclear medicine. We meet once a month virtually. We go over all of our cases for the month, and we decide who gets what, if at all. I don't have published data that looks at pre and post multidisciplinary. We've always sort of had this multidisciplinary arrangement. Intuitively, I would say that one would imagine that having a multidisciplinary arrangement is better than not having one. But I really do think that there are, there are certainly examples of where that multi-D is not available. For example, if at your institution you don't have a thoracic surgeon who can be comfortable doing LVRS, well then, you don't have that piece. So then I think that ultimately limits your ability, because as much as we love putting in valves, if the fissure is not complete, that, by the way, is the second most common reason for exclusion, the most common being inadequate PFTs, hyperinflation. Unfortunately, we cannot proceed, at least outside of a clinical trial, we cannot proceed with a valve procedure. So I think that there are a number of patients who get turned away from a valve procedure that potentially could have had LVRS. So I do think it's important that we have that, that we can bring both to the patient, and also know, really, I think knowing when to say no is more difficult than knowing when to say yes in our field. And I think it takes some time and experience to develop, to better really understand which patients should we stay away from, because it's very easy, unfortunately, to hurt a patient with this procedure. These patients are all very sick. So I think really developing that good sense of who should go, who should benefit, who's going to benefit from conservative management, I think is very important.
Yeah, awesome, awesome. I have a question in regards, what's your follow-up protocol?
We bring them back 2 weeks later with an X-ray. We then bring them back with a CAT scan about 45, 60 days later. It's not set in stone, but at some point within 45 to 60 days, we do a CAT scan. We repeat their PFTs. If the CAT scan looks great, PFTs look great, that's amazing. We probably will just follow them with X-rays and PFTs thereafter. If the CAT scan does not show lobar atelectasis, we look at the PFTs, we look at their symptoms. Now, what is very interesting, and I've noticed this in my patient population, we haven't published on this yet, but we should, if we can get around to it. There is a subgroup of patients that do not develop lobar atelectasis, yet objectively and subjectively they're feeling much better. So their residual volume goes down, their FEV1 improves, and they have no improvement on the CAT scan. And the answer of why this happens is because of perfusion. And we've done perfusion scans post-procedure on those patients, and as you may expect, the perfusion shifts away from the treated lung, and even though there's no atelectasis, but because the perfusion gets redistributed to other parts of the lung that may be healthier, that patient feels better, and the VQ is better matched. And this potentially may highlight the fact that perhaps perfusion is more important than volume for these patients.
Yeah,
it's a very
because
interesting
healthy shunting.
Yeah, it's all about the VQ.
Yeah, yeah. So actually, I have a question because you mentioned one of your teams is a nuclear doc. It seems like you're selective when you order the perfusion. Is that a correct statement, or do you tend to want to have it on all the patients?
We actually started getting them on all of our patients because even in patients who have heterogeneous emphysema that you typically would not get a perfusion scan on. Well, what happens if there is heterogeneous emphysema on both lungs, which is very common? It helps you figure out which
one. Yeah. Oh,
exactly.
awesome.
Yeah.
This is great. Yeah. And then I think we're gonna end with this last question. Post-operatively, when you're dealing with pneumothoraces and then you're putting pigtails, has there been any clinical or anecdotal sort of evidence into what to apply suction, not to apply suction, and that sort of debate? Or is it case by case, depending if the lung inflates without suction or having to use the suction to inflate the lung?
Usually, right. Usually, our approach to pneumothorax management in this patient population is the same as any other post-surgical patient. And at least in my practice, we do pleurodese these patients, although I know that many do not. But what happens is that if you achieve atelectasis, and as a result of that atelectasis, you develop a pneumothorax, but the lung is expanded, then you have options because essentially you can get those, because the lung is expanded, you can get those patients through this period by pleurodesing them. You will see a difference in practice. For example, if you look at clinical trials, that is not what they did. In other words, in clinical trials, no one got pleurodesed. In clinical trials, they would leave you to suction, and if you have a prolonged air leak, then they would pull out one of the valves. So what that does, as you may imagine, is that it undoes your procedure. If you pull out one valve or 10 valves, that lobe is going to inflate immediately, and of course, then the air leak will stop. But then you've undone your procedure. So we don't do that, at least in my practice. We manage them the same way as the surgeons manage their patients. you see, you put them on suction, you see if the leak stops. If it stops, that's great. If it doesn't stop, then you can put them on a water seal to see how, if it's a small leak but it's persistent, I wouldn't pleurodise. I may send the patient home with a Heimlich and then bring them back, take out a Heimlich in the office. If it's a bad leak and I cannot get them on a Heimlich because they get symptomatic, then we pleurodise them with a off of suction on a water seal. We pleurodise them, and then hopefully get them on the Heimlich. So it's very rare. In fact, the only time that I personally will pull the valve out to reverse the procedure is if a patient has unexpandable lung. That's the only time that I would do it.
If the purpose of the procedure didn't do what it's supposed to do.
Well, I mean, I would say that the procedure accomplished, like in that CAT scan video that I showed, yes, the left upper lobe is closed. So the valves did what they were supposed to do. Unfortunately, that patient's lower lobe could not fill the space.
Yeah. I was referring to the terminal outcome where the healthy lung expands and improves the symptoms and everything. Yeah, well, thank you so much. I really appreciate it. Thank you for coming here, and this has been really awesome. And we had a very interesting lecture and questions. I appreciate it, Dr. Eugene Shostak, and thank you so much. And maybe we'll see you a third time.
Yes.
And then,
bye-bye.
Bye. For our audience, if anybody's going to CHEST, we have a very interesting interactive webinar with the Society of Advanced Bronchoscopy board members, and we're talking about building bronchoscopy programs. So if you're coming there, please, this is the address and the time, and we'll see you there. Have a good night, everyone.